Good evening, all, and I hope everyone is doing fine and is well. I, Dr. Dushandal, on behalf of Abbott Primary Care General Medicine Division, welcome you all for this webinar on a very important, pertinent subject with a very eminent faculty today. So, we at Abbott believe that continuous medical education and knowledge sharing would surely improve the patient outcome and continuing our endeavors to achieve this same, we have curated this particular webinar on a very important subject that is on mild to moderate COVID-19. At the outset, I would like to thank the Indian Chess Society, Dr. DJ Christopher, for giving us this guidance and continuous support for coming out with these series of webinar. Today, we are having the third in series webinar, and we got a very encouraging result, encouraging response from all the doctors across India. So, thanks for that, ICS and sir. Uh, Post March 2020, when it has been declared as a pandemic, COVID-19 cases are now being increasing in leaps and bounds, and lately, the cases are now at the level of 80 to 90,000 per day, and this has created a lot of significant burden over the healthcare infrastructure and also posed a burden on the healthcare workers. So, out of these 90 to 80,000 daily cases, almost 80% of the cases belongs to mild to moderate category, and they can be managed. These patients could be managed at home care or at OPD settings with remote monitoring from the treating physicians. So, to throw more light on this, we have our esteemed panelists or speakers for the day, and they would be talking on managing mild and moderate COVID-19 and understanding the course of the pandemic. So we have with us Dr. DJ Christopher, who would be moderating and speaking on the dynamics of transmission, and he is the president of Indian Chest Society, working at CMC Vellore as chief pulmonary physician. Also is vice president of the Indian Association of Respiratory Care, and it's being on editorial boards of multiple PubMed index journals like Lung India, Indian Journal of Chest Disease and Allied Sciences. So I welcome you, sir. Next, with us today, we have a very dynamic and passionate chest physician, Dr. Zarir Udwadia. He is a consultant chest physician at Hinduja Hospital, Reach Candy Hospital, and Parsi General Hospital. Sir is having special interest in TB, MDR, TB. He is a prolific researcher having multiple publication in his name. He has been invited to deliver lectures at various forums at international and national levels. Sir is being an advisor to the WHO on TB and MDR TB guidelines, and he is also on the core committee of doctors elected by the Indian government to inform Bombay's COVID-19 pandemic response. So, sir, I welcome you all, and with them we have a very young, dynamic ma'am, Dr. Amita Nene. He is currently working as an HOD and senior consultant at Department of Pulmonary Medicine, Bombay Hospital, having more than 50 publications in her credit. Has also authored certain chapters in pulmonary textbook. Is a recipient of Young Achiever Award in field of pulmonology, and Madam is an active member of ICS as well as different association of pulmonology and bronchology. So welcome all, and it's an indeed pleasure to have all of you with us today for this very lively webinar. And I sincerely hope that everyone out there who is going to attend the session today would surely have certain fruitful learnings on managing the cases of mild to moderate COVID-19. So without a further ado, I would now like to hand over the proceedings to our moderator and first speaker, Dr. DJ Christopher. So, sir, over to you for further proceedings. Thank you.
Can you see the screen? Can you see the screen?
Yeah.
Okay. Thank you.
Full screen mode. Great.
Yes. Thank you, Dushyant, for those kind words of introduction, and thanks to Abbott for inviting us to speak in this forum. I am privileged to speak along with two of my friends and colleagues, Dr. Zarir Udwadia and Amita Nine, both very knowledgeable and dynamic. And I'm sure together we will present to you up-to-date and exciting information about the COVID-19, the part of COVID-19 care that is less talked about, that is very important. And as was alluded to, is responsible for 80% of COVID-19 disease. And these patients have to be managed, and we need to talk about it. So this problem, as all of us know, started in Wuhan, a large crowded metropolis. And because it was a manufacturing hub, it was economically extremely important. A lot of people visited Wuhan, and therefore they took the virus also back to their countries, which facilitated global spread of the disease, and it made its way from Asia to Europe, America, and also back to Asia, as countries like India are now in the thick of the problem. These are worms that depict the progress of the pandemic, and these are the daily cases. And what you see here is the Indian trajectory, and India reports the highest number of cases today. And I am looking, not expectantly, but at a time when India would have the highest number of total cases as well. The credit of which goes to US at the moment, and I fear the time when we will have the most number of cases. It's not a good scene, but this is reality. And in addition to this, we read news items like this, health professionals sensing that the number of cases they read about in the newspapers is not exactly the number of cases they report as dead in their hospitals and in the neighboring hospitals. And there's fear that perhaps we are not seeing the full story. I want to go back to the Spanish flu, since a lot of the learning we have about managing flu comes from this pandemic. And I want to take you through this one scenario that is the basis for social distancing. When this flu set in, the first case was reported in Philadelphia on the 17th of September. And on the 3rd of October, they realized that they have to put in social distancing measures, and they did that. And there was a huge spike of cases and also a lot of deaths, since the healthcare system could not cope with this. St. Louis, another city, it had its first case reported on the 5th of October, and they had learned from Philadelphia. So they enacted social distancing on the 7th, 2 days later. And this is the trajectory of St. Louis. There's a very flat trajectory, although it goes for a longer time, and it also has a second bump. It was never large enough to overwhelm the healthcare resources of the cities, and therefore less people died. And this is exactly what we are trying to put in place with the lockdowns and social distancing measures. What was the expectations from lockdown in our country? We expected to lock down till the cases were on the decline. We expected to ramp up testing and tracking and isolation. And we also wanted to gear up our healthcare systems by increasing bed capacity, increasing ICU ventilator capacity, and redeployment of our healthcare workers to be able to cope with the increased load of these patients. This is the actual trajectory of the pandemic in different countries. I have shown you some European countries. Take, for example, Germany. You see that the lockdown was instituted as they were climbing in numbers, and then they reached their peak and they were on the way down when the lockdown was released. Likewise with Spain, lockdown instituted here as they were beginning to rise, and then the release of lockdown by the time the case numbers were dropping and manageable. So the same story for Italy and UK. But in India, we instituted lockdown very early, and I think that is commendable. But we were still in the upslope and climbing when the lockdowns were released. And as we speak, lockdowns are being released, and the case numbers have climbed more steeply after the lockdowns. There are some other ground realities we need to contend with in India. There are 176 million people who still live on less than $2 a day. That's about 140 rupees. And only 1% of GDP is spent on public health care. The Indian government spends only about $13 per person on healthcare per annum, whereas China spends $398. The second concept that we all need to understand is what is called herd immunity. And the principle is that if there are enough people in a community that develop protection, which can happen either with infection or with vaccination, if critical number of people are thus protected, then it protects the vulnerable in the community, since there are not enough people to transmit the virus across the community. So the vulnerable, who are the elderly, the immunosuppressed, those with cancer, and those on immunosuppressing medications and so on, are all protected because the critical number of people in the community have now become protected. It is estimated that 60 to 70% of the population needs to be infected for herd immunity unless a vaccine comes by. And we are all expectantly waiting for the vaccine, and I hope and pray that the good day of a successful vaccine coming in is not far away. In the context of herd immunity, we have to see how far we have got with regard to the infection. So this is the survey done from Delhi, and as you may recall, this happened in the aftermath of the peaking of cases in Delhi. And across different segments of Delhi, these are the reported prevalence of antibodies in the population, randomly chosen population. So the weighted average is 22.83, let's say 23 people. So an average of 23% of the population of Delhi has been exposed to COVID-19 and probably has resistance, which also means that 77% of the population is still vulnerable. And so the non-pharmacologic interventions such as physical distancing, use of masks, and hand hygiene and cough etiquette all need to continue to be in place. And so this problem, in my assessment, is unlikely to go away soon. We learned a lot of lessons from some of the early disease spread models. One of them is Diamond Princess cruise ship, where 3,700 patients and crew were on board. And on the 25th of January 2020, a passenger departed and subsequently got diagnosed to have COVID-19. And on the 3rd of February, the ship was quarantined. All the people were subsequently screened, and 19.2% were positive for SARS-CoV-2, and 46.5% of them, let's say approximately half, were asymptomatic. Some of them subsequently developed symptoms, and eventually the modeling showed that perhaps 18% of the population exposed, infected, may actually remain asymptomatic. Now, in terms of transmissibility, it is easily transmitted. The transmission is measured in what is called R0, which is the number of people a single patient, a single case will infect. And this is 2 to 3 for COVID-19. This is not higher than several other infectious diseases, but this virus is special in that although its contagiousness is highest in the first 3 days after onset of symptoms, the transmission actually happens when they are pre-symptomatic. And there are several people who are asymptomatic and spread the disease, never knew that they had the disease, but they have been spreading the disease. I believe this is the single most important reason why this virus has spread like wildfire globally. There are some other transmission amplifying situations. These include prisons, long-term care facilities, cruise ships, sports venues, community gatherings, religious gatherings, healthcare facilities, and of course, schools and educational institutions are not part of this. And although it sounds encouraging, the fact is that these have remained closed virtually throughout this pandemic. And we will only know the truth when they are opened subsequently. The modes of transmission are predominantly droplet, but aerosol transmission is believed also to happen. Let's, for the moment, not talk about airborne transmission. The other important modes are fomite transmissions, which is by deposition of infectious particles on surfaces, which then can be by contact transmitted to a vulnerable person. Fecal isolation is 29 to 55%, but is unlikely to be an important mode of spread. Blood 1 to 12%, again unlikely to be an important mode, and urine 0. This is the dynamics with regard to spread. Since the predominant mode of spread is respiratory droplets, these droplets will settle within a diameter of about 2 meters. So this is, if people are beyond that, then the chance of them getting infected is extremely low. But coughing and sneezing can propel the particles much further. This was a study that looked at the distance these infectious particles can travel, and it was 23 to 27 feet. It's a long distance. And if you put back this model, then you are not looking at 6 feet or 2 meters anymore. You're looking at much farther than that. 26 feet is there. And this is a matter of concern. And so we need actually to stop this from going beyond the person by some form of source control. And this is the one that is most popular and perhaps is effective is the mask. And some studies that have looked at the efficacy, this study looked at 111 subjects with one or more respiratory viruses by RT-PCR. This is not COVID, this is before COVID. And they had either seasonal coronavirus or influenza or rhinovirus. They looked at the 30-minute exhalation breath, and they collected the breath. And then they used the aerosol collection device to capture the exhaled breath particles. And this is what they showed. They showed that, I will just look at the coronavirus data. It is not SARS-CoV, it's another coronavirus responsible for perhaps a seasonal kind of viral respiratory infections. So in this, they showed that when they were able to only demonstrate 3 out of 10, they could demonstrate respiratory particles. And in those with and aerosols in 4 out of 10. So droplets in 3 out of 10, and this is the droplets, and aerosols in 4 out of 10. This is the aerosols. And no virus was detected in subjects wearing the mask. That is this group and this group. And so it is clear from these studies and other studies that face mask is an effective source control. And none other than Nature Medicine has stated that face masks reduce respiratory virus shedding in exhaled breath. It is fairly conclusive and authoritative. Therefore, in social settings and of course in hospitals, it goes without saying that we have to ensure that everybody wears masks to avoid transmission. That includes patients, healthcare workers, and their attendants. This is a model that looks at transmission, and the first scenario is an individual without wearing a mask, and these are the infectious particles. And this is a potential person who could get infected, and you can see that he has exposure. This is the second scenario where the individual does not wear a mask, but the individual who is potential to be infected is wearing a mask, and still there is risk. And this is a scenario where this individual wears the mask, and the second scenario was that this individual doesn't wear a mask, but the other one does. But the third scenario is when the person who is infected wears the mask, And then you can now see how the infectious particles are so much less, and the chance of this individual getting infected is much lesser. And the best scenario is that both are wearing masks. Now, this is the evidence I was looking for quite some time, that are mask wearers themselves protected? We know that mask wearers protect others, but is there evidence that we ourselves get protected? So there has been a concept that viral dose, the amount of viruses you inhale, is related to the disease severity. This information comes from animal studies. In July this year, researchers published a paper showing that the viral dose was related to disease severity in hamsters exposed to coronavirus. And which means that the hamsters that received a higher dose of infectious inoculum got more sick than hamsters who got infected with a lower dose. And in 2015, researchers tested this concept in human volunteers using non-lethal flu virus and found the same results. So we now know that if we wear a mask and get infected, there's a good chance that the intensity of infection will be less. So viral inoculum or dose is related to severity. High dose affects the tissue more extensively, and it also overwhelms the immune responses. And we all understand the immune going haywire with COVID-19, and we all have heard about the cytokine storm. These are all not the direct effects of the virus, but the indirect effect caused by the immune response that has got triggered disproportionately and in a not in a focused fashion. And all this can cause damage and therefore more severe disease. Just information about fomites. So how long does the virus remain viable with fomites? So in plastic, it is the longest, somewhere between little above 48 hours, and in stainless steel, little less than 48 hours. In cardboard, it is about 24 to 36 hours. In copper, it is the shortest, it is about 8 hours. And of course, when aerosols are generated, they don't deposit, but they float. And so at least for 3 hours, they continue to remain viable. So this is information we all need to know. And this is the reason why if we have to reuse the N95, it is good to let it remain in a closed dry space for at least 48 hours, preferably 72 hours, and then the virus would have died. I want to share one study before we close. This is a recent study done at the Massachusetts Hospital. This is to look at the role of children in transmission. So we have so far believed that children are not very susceptible to the disease, and therefore they are unlikely also to be transmitters of the disease. So the study looked at 192 children of 10 years age, mean age, and 49 children, 26%, had acute SARS-CoV, and 9% had the immune reaction, immune syndrome of that children come down with after the viral infection. And 51% of the children infected presented with fever, and 49% never had fever. And if symptoms of SARS-CoV were present in those children, it was non-specific and small. In other words, many of these children will never be detected as having the infection and may never get diagnosed. They looked at the nasopharyngeal viral load on subsequent days, and they found that the viral load was very high. It was higher than hospitalized adults with severe disease. Who are the hospitalized adults with severe disease? They went to the critical care and took swabs of individuals there, and they showed that the children had higher loads than the very sick adults. Age did not impact viral load, and younger children had lower expression of ACE2. Now, ACE2 receptors are the key for the virus to enter, and this explains the reason why children are less susceptible to the infection. So children have lower numbers of immune receptor than adults. This makes them less likely to get infected or seriously ill. This does not correlate with a reduced viral load. And according to the authors of the study, children can carry high viral loads and are more contagious regardless of their susceptibility to develop infection. Now, this is particularly important in the context of reopening schools. And many countries, and our own country, has been thinking about it. And then this is an important factor. We have to see if we do not open a Pandora's box when the schools reopen. In conclusion, we are in the midst of a pandemic, and probably none of us in our professional lives have encountered anything like this. The pandemic has peaked in many parts of the country, but we still have a long way to go, and we have several peaks to tide over in different cities first, then I think smaller cities and towns, and then the rural parts of our country. And there it can remain silent because they are not so important to the media, not so important to the policymakers, but it may take a serious toll, and the reporting may not capture the magnitude of that problem. This virus is transmissible and predominantly by airborne transmission. Social distancing, masking are crucial to control the pandemic. Children have mild disease but may harbor a huge viral load, and that is may be important from the point of view of transmission of disease. Thank you very much. May I now invite Dr. Zarir Udwadia to give the next lecture. He has already been introduced, and I can assure you that you are in for a feast. Over to you, Zarir.
Doctor, please unmute.
Yeah, thank you. And please set up my presentation to play.
Yes, doctor.
Come on, what's up?
Yes, sir. 1 second. We're just putting it on.
What's up?
I just stopped sharing, so give it another try, Zarir.
Sure. Come on, guys, that shouldn't be difficult to do. Good evening, everyone, and I'd like to thank DJ for always setting me such thought-provoking and stimulating topics. He's asked me to speak on home care for COVID. Who can safely be treated at home and how you would appropriately treat such patients. As you all know, COVID-19 is a spectrum. And of course, as hospital physicians, we end up with the extreme end of the spectrum, the 15% with severe pneumonia and 5% with ARDS. But let's not lose sight of the fact that 80% of patients have mild asymptomatic infections, mild pneumonias, and do not need to see the inside of a hospital. So theoretically, up to 80%, the great majority of patients can be home treated which is the topic of my discourse. And this is the seminal article from Lancet, from the epicenter of the pandemic in Wuhan, which told us a lot about the clinical cause and risk factors of this infection. And I'll tell you why I put this up. Because if you focus on the round circle at the bottom of the screen, you will see that out of 1,500 patients in Wuhan at the very start of the COVID pandemic, 81% had mild infection. The larger green circle, 14% had severe, and 5% had blue. But I've also put up this slide for another very important reason, this graph here. Let me run you through this because it is of great clinical importance. They've taken different symptoms and they've looked at days on the x-axis. So fever, for example, starts at day 1 as you would expect and generally ends around day 12. Cough, for example, when your patients ask you how long will it go on for, starts up front early and goes on generally till about day 19. But you have a narrow window of opportunity. Dyspnea, the most frightening symptom because it denotes that the infection has traveled downwards into the lung, generally takes place not in the first 5 days, but generally around day 6 or 7. Admission in the hospital is around day 7, and development of ARDS is around day 10. So as I tell my patients who are being hope treated, don't get complacent. The critical period is around day 7 to day 10. But who can safely be treated at home? It's an important decision you're often called on to make. Someone with mild disease, yes. Someone with moderate disease, perhaps, but he must have low risk of progression. And that means no or few comorbidities. No adverse prognosticators. Facilities for self-quarantine. You can't really be safely treated at home if there are 15 people in a small shanty flat. A doctor must take over personal responsibility to hold your hand and guide you through these critical 2 weeks. And of course, you have to have a reliable patient, one who can be relied on to be monitored closely for the progression that we talked about, which usually occurs around day 7. And there are basic requirements for home care, which the Indian Health Ministry has laid down. And I'm not going to bore you with details, but these are what they are. And the CDC in America has given you similar guidelines, and they need you to tick all these boxes before home isolation. So appropriate caregiver available, a separate bedroom, a bathroom, etc., etc. But I think we can and should be a bit more ambitious, a bit more broad-reaching than this. And I'm going to put up this very provocative newspaper article written by 2 dear friends of mine, Ravi Mehta and Jatin Kothari, a pulmonologist and nephrologist respectively, who wrote that when they analyzed the Maharashtra government website details, 70% of COVID-19 patients are asymptomatic. Those were the days when people were literally forced into hospital. That 30% was symptomatic, therefore, and only 5% of these were critically ill and required ICU care. That left you with a good 1/3 of symptomatic patients, not the asymptomatics, which certainly don't need to go into a hospital, in my opinion, but 1/3 of symptomatic cases only needed oxygen. And they made an eloquent case in this article for that oxygen being administered at home. So if you are brave enough as a physician, they argued that you should and could be treating such patients at home, even when they were breathless, even when they were mildly hypoxic, provided you know your limitations at home. Now, in the JAPI, right at the start of the pandemic, we wrote this review article reviewing the prognostic factors for adverse outcomes. And clearly, if your patient has one of these prognostic factors, you would be very brave or a bit foolhardy to be trying to control him at home. So elderly people, I hate age more than 55 because it puts me in that category, comorbid conditions, uncontrolled diabetes, poor respiratory reserve, morbid obesity, you know what they are now. Immunocompromised patients, someone with cancer or end-stage kidney disease, and certain important lab parameters, an elevated D-dimer, an NL ratio more than 10, a very high CRP and other inflammatory markers, a lymphopenia, total count more than 1,000 lymphocyte count, and a high CT severity score, again an adverse prognostic factor. Well, if you have any of these, as I said, you should not be treating such patients at home. And this is a nice cartoon from the CDC. And look at these yellow boxes here. And they say your risk of hospitalization will increase as shown if you have any of these. So if you're asthmatic and you do catch COVID, you're 1.5 times more likely to need hospital care. If you're hypertensive, it's 3 times. Obesity, BMI more than 30, 3 times. Diabetes, 3 times. Severe obesity, 4.5 times. A combination of 3 or more conditions, 5 times. So you have some idea of which patients it is prudent not to be treating at home, because if these patients with these comorbidities do catch COVID, then they're going to run into trouble and almost certainly require hospital. This is how I approach the problem. This is our approach at the Hinduja Hospital, and these are the guidelines we have formulated there. The first step is to categorize the risk of progression to hospitalization when you first see that patient. And here you just have 2 categories. Is your patient low risk by virtue of his age or her age and no comorbid conditions? Or is he high risk because he's older than 55 and does have the comorbid conditions that I outlined? That's the first step. What is the risk of progression? The second step is to determine, when you see the patient, the severity of infection. And I won't bore you with details, but is that patient having, in your opinion, mild infection? And I've written out the symptoms here, a moderate infection or a more severe infection. So we said, what is the chance of progression? Step 1. What is the severity of infection? Step 2. And then you can decide the level of care which is appropriate for that patient. So if it's mild disease with low risk of progression, i.e. category A, yes, of course, you can safely home manage such patients. And many, many patients, the majority will fall into this window. If it's mild disease, however, but it's a high risk patient, remember high risk as defined by age and comorbid conditions, then you should perhaps admit for monitoring, and perhaps one of these huge jumbo centers which we have thriving in this city might be the appropriate triage spot for such patients. But if you are braver and are going to take over the care of this patient with confidence, then home is a possibility for mild disease and high risk. It depends on the physician. If you want to play it safe, the jumbo center. If you want to accept the responsibility and the patient refuses hospital, you have the option of careful home treatment here as well. When it's moderate disease or severe disease, although my colleagues, Dr. Kothari and Dr. Mehta, have argued for possible home treatment even for the moderate category, I would say it might be more prudent, unless you don't have a bed, to admit moderate to a dedicated COVID hospital and ward, and severe disease, whether it's category A or B, high risk factors or no risk factors for progression, severe disease would equal ICU care. But that is just the tip of the iceberg. Only 5 or 10% of all your COVID patients will come into this red band. Can a scoring system help you triage and streamline this process, making it easier to stratify the level of care? Well, the NHS site in the UK has an early warning score called the NEWS2 score, which will help improve the detection of acutely ill patients. Look, they're very, very conservative in the UK. Patients literally stay at home until they're really desperately in need of coming into hospital. And this triage system, which looks at fairly basic parameters, which a GP can even monitor remotely, and then ends up giving you a score, I won't go into details, gives you whether your patient is low risk, medium risk, high risk, a very similar but objective scale compared to the more qualitative scale I talked about earlier. And really there are 3 scales if you want to use them. The Curb 65, which all chest physicians know are useful for pneumonia triage, the NEWS2 score I spoke about from the UK, and the SOFA score, the Q-SOFA score. And when these were put head to head, they found that the NEWS2 score predicted poor outcome 72 hours later with a sensitivity of 92% and a negative predictive value of adverse outcomes of 98%. So if you have to use a score, this is the one to use. Okay, once you've decided your patient can be safely treated at home, the next step is knowing what drugs to use and, more important, what drugs not to use. So this is the kind of prescription I saw just on the 20th, a few days ago, in a teleconsult with a patient from Delhi. I've cancelled the name of the physician to be polite, but he was an MD. And it's a long prescription, first of all, you'll notice. And I've learned over the last 30 years of being a doctor that the shorter the size of your prescription, I would say the better the doctor you are. So we don't want 10 different medicines to confuse the issue. And I've circled two, which I have strong objections to: ivermectin and doxycycline. And for some reason, these have not left the pen of prescribing Indian practitioners. So we wrote in an article in the Indian Express, this was a colleague, Sachit Balsari from Harvard University, what works in COVID treatment and what doesn't. And let's look at what doesn't, what not to use. Antibiotics, no role for azithromycin and doxycycline. Why give them in a viral infection? Doesn't make sense. HCQS, the saga of HCQS should finally come to an end. It does not work in COVID from the evidence that we have accrued so far. If the evidence changes, I'm happy to change my viewpoint. Ivermectin, an anti-parasitic drug, where in the world did that come from? On very, very flimsy evidence for sure. Oseltamivir, it's a drug for influenza, a different viral infection. It doesn't mean it will work in COVID, it does not. And ribavirin is another antiviral drug which doesn't work. This is actual advice from the Australian government. Ivermectin has not been demonstrated to be safe or effective, was their advisory. The Annals of Internal Medicine, in an editorial, said the saga of HCQS must meet its sad end. It's time to move on from HCQS. And please, I would urge all of you to move on as well. And I like this quote from Vinay Prasad in Medscape, who said, for a sick patient with any other viral illness without proven treatment, I've never witnessed doctors giving 5, 6, or 10 drugs, as you saw in the prescription I put up earlier, to treat a virus without any proof that it will help. I've never seen a severely ill patient with influenza or HIV receiving vitamin C, zinc, HCQS, tocilizumab, all without any evidence. With COVID-19, the primary rule of medicine, first do no harm, appears to have been discarded. What are the drugs that I would be happy to use? The COVID-specific drugs, that is, in the treatment at home of COVID-19. There are just 4: favipiravir, steroids, anticoagulants, and oxygen. Let's run through briefly all of these. Favipiravir is an experimental antiviral drug, a viral RNA polymerase inhibitor. It has been stockpiled by the Japanese government, which first used it for influenza. It's not yet got FDA or EU approval, but is available in quite a few countries now. This list has expanded to include Saudi Arabia, Brazil, and of course, India as well. It's a broad spectrum antiviral acting against a broad array of RNA viruses, including Ebola virus. Not going to go into details. There are some advantages. Mainly, it is oral. It's moderately priced, it's safe, it's easy to mass produce because it's off patent. It's probably more effective in the mild to moderate cases. No one would dare use it in a more severe case where remdesivir is the drug of choice, but that is not part of our purview because we're talking of home treatment. It must be given early to be effective like any antiviral. The disadvantage is the high pill burden, though that has been bypassed because strengths of 400 and even 800 milligrams, I believe, are now available in the market. Along with two colleagues at the Hinduja Hospital, we wrote this review article on favipiravir in the Elsevier Journal group. And we raised some concerns about the fact that the data was a bit thin, not very well peer-reviewed data, Russian and Japanese databases. I was one of the PIs for this Indian study, but had to admit that the study was still under review. And we have our fingers crossed for a favorable review. But the DCGI approved it on the 17th of June, and the drug is here with us to use. Let's move on to steroids. This was a red light day, really, in COVID treatment history, because on the 16th of June, this famous recovery trial group from the UK, headed at the University of Oxford, this is a large, pragmatic, randomized controlled trial, which is conducted to the highest scientific principles and has given us a lot of information about treatment options in COVID. Well, they announced that they had found that low-dose dexamethasone, a steroid, reduced death by up to one-third in hospital patients. This was a drug which was as cheap as water almost, which had been shown to be highly effective and change mortality when none of the drugs before this and none of the drugs after, from remdesivir to plasma included, had been shown to have the same mortality effect. They published their findings a little later in the New England Journal of Medicine. Large numbers of patients, I won't go into details, 6 milligram oral or IV with typical British conservatism for just 10 days or less if the patient was discharged earlier was the dose they chose. And the results were extremely gratifying because there were great improvements, especially in patients on ventilators, those needing oxygen, but there was an important clinical proviso. And I want that message to be hammered across that DEXA was of no benefit and possible harm if it was used in those not needing oxygen. And DEXA was more effective when it was used late in the illness, not right up front at the start. And based on this data and the evidence from this study, the study closed the DEXA limb, and DEXA became the standard of care in hospitals big and small across the globe. So it's great when science and scientific development keeps pace with this pandemic. And this was the important observation that if you were not needing oxygen, you actually did worse if you received DEXA. Look at that here as well. This is usual care and DEXA, but in the group where no oxygen was needed, the DEXA patients actually did worse. So don't take steroids in mild cases. Don't take them early seem to be the message, because in the early phase of the illness, your immune system is your friend. It is fighting the virus, and dampening it with steroids may not be a good idea. But indeed, dexamethasone is the first life-saving coronavirus drug and the only one to date, to be honest. So if I had to give you the quote from Paul Sachs at Harvard, he says, it's hard to imagine not offering DEXA today to a patient with COVID-19 needing ventilation or oxygen. They will live longer, and that's good news. It's not just a DEXA effect, it's a steroid effect, because this was a matching trial on hydrocortisone. Again, small doses seems to be the message, 50 milligrams 6 hourly for 7 days, which resulted in 93% probability of being organ support free at 21 days. And this is a systematic review of all steroid articles, again showing in the forest plot that steroids seem to make a big difference. Why have I brought up steroids in a talk on home treatment? Because DEXA can be used orally or equivalent steroids, but let your patient be breathless, maybe have a drop in saturation, and don't use it up front. The right dose at the right time in the right patients, patients in hospital for sure, on oxygen needing ventilators, ideally in the second week, and resist the temptation to use the industrially huge doses like 500 milligram pulses of methylprednisolone, which are currently in vogue in this country. Anticoagulants are a drug that you can use at home for your COVID patients, because we know that a thrombotic microangiopathy involving the small vessels of the lung is the pathological hallmark. These green arrows point to microthrombi in patients who die from COVID. So COVID-19, I like to say, is a serial killer with 2 bullets, the first for the lung, the second for the vascular side. And when I put in blood clotting in COVID-19 in a Google search, I got this staggering total of 2.5 million hits. Can you imagine how fast scientific progress is included? And this article in Circulation is representative. DVTs were noted in 85%. That's a staggeringly high rate of DVT incidents, COVID-19 patients in a Wuhan ICU. Have a low threshold for use of anticoagulants, be guided by the D-dimer. In hospital, use LMWH. If you're at home, you can use apixaban 2.5 BD. That is my anticoagulant of choice, but without any evidence to say that that is superior. And now I'm going to wind up this presentation with a case which puts everything I've said, treated at home, into perspective. So let's run through this together, because she's a very interesting case. It checks the limits of how far you're prepared to go when you treat someone at home. She was a 45-year-old homemaker, no comorbidities, so category A, limited risk of progression at her age and without comorbidities. And this is the usual presentation of COVID, isn't it? 1 day of fever, 99.5, sore throat, husband had just tested positive for SARS-CoV-2. Otherwise, she said she may have ignored her symptoms. She consulted a family practitioner by video consult, and he involved me for further video consults and guidance. And in these tech-savvy days, that's how I often interact with quite a few general practitioners. So the first day of her illness, she had a low-grade fever, nothing special, no cough, good saturation level, WBC count, which was reasonable, no red flags, CRP, which was normal, D-dimer, which was normal, and she seemed to be okay. And my assessment was mild disease, no risk factors, safe to treat at home. And what treatment when I was asked? I said symptomatic treatment, nothing else. But by day 3 of illness, her fever was now spiking at 102. Her CRP had gone up. Her D-dimer was the same. I said, let's organize a portable X-ray. And although her saturation was still 97%, the X-ray showed minimal bilateral shadows. The infection had moved from the upper to the lower respiratory tract. My advice was, let's start favipiravir in the right dose. And you will agree that this is not a normal X-ray, but despite these bilateral lower lobe infiltrates, she had a normal saturation. She said, Doc, I'm not feeling breathless. Day 3 to day 6, I was feeling pleased with myself and the course of her illness because her fever had settled. There was a slight dry cough. Her saturation was rock steady at 96%, and we continued treatment. Fever beyond day 7. Remember the slide I showed you up front at the start? Fever beyond day 7 from the onset of illness is unusual, and it does identify a patient who has adverse outcomes. Cases with prolonged fever in this Chinese study were more likely to require eventually ICU admission. Patients with prolonged fever have higher levels of interleukins. On day 7, worryingly, her fever recurred. Her cough was worse, now accompanied by hemoptysis. D-dimer was double of what it was last time. And this is of course, the red card, isn't it? Your saturation, which every patient has become adept at monitoring, whether they need to or not, had dropped to 92% at rest and 89% after I asked her to walk 6 minutes in the bedroom in front of me, i.e. remotely. So what next? There was panic in the family. The question thrust at me was, now, please, we want to hospitalize. Or do you really want to continue the home care that you had advised at the start? But of course, as happens when you really need it, there was no bed at the 2 hospitals I work at, partly because they're full of patients who don't need to be there. Asymptomatic patients, mild patients, patients who panic, GPs who panic and insist on hospital care. So the patient and family had no option really. They were stuck with me and our team, but to continue home treatment. What did we do? We continued favipiravir because that's the only antiviral you can give at home. We commenced her on tablet Dexa because I was convinced in terms of the timing, the rise in the CRP, the rise in the D-dimer, that this patient was undergoing a mild cytokine storm. I added an antibiotic without any firm scientific rationale, I would agree. We started anticoagulation because her D-dimer was high. We got oxygen organized. Even that is difficult. An oxygen concentrator is not easy to get, in these COVID days. We encouraged her to self-prone and start breathing exercises. And all of these are measures that you can give at home. The favipiravir, the steroid, the anticoagulation, and the oxygen we talked about. And very, very fortunately, and look, COVID is like a lottery in the second week. I don't think it was thanks to us. It's just the natural history of her disease in that particular patient. Her fever settled, her oxygen level improved, just on low grade, low dose, 1 to 2 liter oxygen. Her WBC and her CRP improved, her D-dimer normalized. We could stop the antibiotic, the antiviral, the oxygen in just 3 days. The patient and the family were relieved and happy. And the doctors wiped the sweat from their collective brows. But it's not over. And really, this disease has taught me to expect the unexpected. Because I had a final teleconsult at day 25 when she said, Doc, I'm feeling worse now than I ever felt before. Day 25 of illness. My feverish feeling is back every evening. There's a complete anorexia. My chest aches as though a steamroller is on top of it. And I have not slept well for the last 1 month. Was it a relapse? Certainly not. we were dealing with the post-COVID syndrome, the long COVID syndrome. And it's a great array of symptoms, literally from the head to the toe, which affect COVID patients after they have cleared the virus. They're probably PCR negative by this stage. And this is a long list of symptoms which I won't go through. And this was the original article in ERJ, which highlighted the presence of this syndrome. 113 members of two face groups for patients who had recovered in Netherlands and Belgium gave all their symptoms online, and look, only 13% were completely free of COVID symptoms 90 days after the onset of COVID. 3 months later, our patients are suffering with fatigue, with dyspnea. 30%, a third, still have one or two symptoms, and 55%, half, have 3 or more symptoms. Only 0.7% of our patients are symptom-free 90 days after their COVID symptoms. And that just shows you how each symptom fares over time. And that just shows you how our patients who start with green and good health, 90 days later are often red and bad health about 30% of times. They call this the long COVID syndrome. So I'm going to end by giving you my 10 principles of home care of COVID. Know who it's safe to treat at home and who you must move to hospital. Take on the responsibility of patient care only if you have the time and the stamina. The only predictable feature of COVID is its unpredictability as it's seen. Be prepared. Few, if any, treatments of COVID are proven to be effective. Use drugs only if they have a strong evidence base, please. Avoid the compulsory prescription of drugs like you saw in the prescription I gave you, just because our patients and their families and their general practitioners expected. Polypharmacy serves no purpose. The majority of COVID patients can be managed at home, and they will need no treatment. A healthy immune system is the best defense you have against COVID. Support it. Good food, good nutrition, vitamins. Most drugs used in the treatment of COVID will do more harm than good. Avoid them. Monitoring is more important than treatment in my opinion, especially saturation. Make use of technology, but don't become a slave to it. There will be a time when, of course, you have to physically put your stethoscope on your patient to see if they're wheezing, to see if they have crackles. And your responsibility continues longer, much longer than 2 weeks, because of this post-COVID syndrome, or long COVID syndrome, which I've learned is very, very rare. So in conclusion, for home care to succeed, you need a patient who is intelligent and motivated. You need a doctor who's committed. You need a family who is supportive. You need the right drugs and equipment and knowledge of the right drugs to use, which I hope I've imparted to you. And you need to be prepared to daily monitor these patients, ideally having a hospital backup plan in place. Thank you.
So
Thank you, Zarir. It's an excellent presentation. Very lucidly presented concepts of care. Now we have Dr. Anita Nine, and she will give us a very practical lecture of how we go about looking after these patients. And over to you, Amita.
Thank you very much, Dr. Christopher, to invite me for this very interesting webinar. I'd like to thank Award for actually thinking about this very interesting and need of the hour webinar. Before I start, I must confess that actually I'm quite nervous. I'm feeling as if I've been put between two big lions, and how a lamb would actually feel sitting in between two big lions. But I'm sure I'll be able to smile my way through. So I'm going to be basically talking about appropriate settings for treating COVID patients at home and for protecting.
Ma'am, sorry to interrupt. The presentation isn't shared yet, ma'am.
Is it okay?
Zarir, have you removed sharing?
Yes.
Okay.
Just a minute. I'm just doing it again.
Yes, ma'am. Just come back to the browser and then share screen, ma'am.
Yeah. Has it got shared now?
Not yet, ma'am.
Okay.
You'll have to click on share screen and the
Yeah,
your entire screen option.
Yeah, okay.
Under your entire screen option, ma'am, there will be that screen. Click on that and then the share button will become
Just give
active.
me a minute, please. Just a minute.
Sharing.
Can you just give me the sharing ability? Because it's not allowing me to share.
Ma'am, it is allowed actually. You can see the share screen button at the center bottom, ma'am.
Yeah, but
Just click on that, ma'am.
I know.
The window will open up. You can see your entire screen option. Can you see that option, ma'am?
I can see the option, but it's not getting shared somehow. So
Can you see now?
Yes, ma'am. It is shared now. I can see your
now
screen.
is it shared now?
But it's not the presentation.
Means?
Some email is getting.
Okay.
It's on another screen now.
Okay.
Under your entire screen, ma'am, you can just tap on that screen once, then the share button will become active.
Yeah, I think it's done now. Is it
Yes,
correct?
ma'am. Yes, ma'am.
Okay,
Yes.
fine.
Great. Stop sharing.
You can continue, ma'am.
Okay, fine. So thank you again, Dr. Christopher, inviting me. Thank you, Abort. I'm sorry for this technical snag on my side. It's really challenging following two giants, Dr. Christopher and Dr. Udvadia, give to talk after them, but I'm going to try my best. So I'm going to be talking today about appropriate settings for treating COVID patients at home and protecting household contacts. So a very interesting paper came out in Lancet in May 2020, and this paper was trying to basically see whether institutional care or home-based care would be able to better contain the COVID-19 outbreak. And in the study, it was found that home-based isolation caused an 8-day delay in the epidemic peak, whereas the institution-based isolation created a peak delay of 18 days. So from the study, it's very, very evident that if we treat the patient in the institution, then we are going to be able to better control this disease. Then why are we having this webinar? Why are we talking about offering home care to COVID patients? And to make this webinar interactive and more interesting, I have actually divided this entire talk into 13 important questions that we may have to answer or go through in our head before we want to advise home care to our patients. So why home care for COVID patients? The question number one. So this question has a very important answer. So on 16th of September, Times of India headline showed this, that after US, India has become the second country to reach the number 50 lakh of COVID patients. And what is really unfortunate is that the last 10 lakh number was achieved by us in a small gap of 11 days. And in one day, around 90,000 patients of COVID are getting identified in our country, where we are not even testing very, very frequently. So basically, when so many patients are going to be diagnosed every single day, how do we actually manage to admit them? So let's talk about COVID numbers of Maharashtra and Mumbai of yesterday. So on 24th September in Maharashtra, the total number of new cases were 19,000 and total number of discharge cases was 17,000. So here there was a surplus of 2,000 patients who would have ideally required a bed. In Mumbai, yesterday, the total number of new cases was 2,100 and total number of discharge cases was 1,500. And again, there's a surplus of patients of 600. So if every day there's going to be a surplus of patients, then how do we create any healthcare facility or beds to treat all these patients? And this is the reason we want to talk about home care for COVID patients, because the COVID numbers are persistently increasing. It is therefore not possible to admit each and every COVID patient due to the non-availability of the beds. Also, many patients are uncomfortable getting admitted because they don't want to be alone. They don't want to be out of sight from their family members, and therefore they just don't want to get admitted. Often we have elderly people who are dependent, they are handicapped. We can't just leave them alone in a COVID ward, or we have people who have small children to look after, and therefore they cannot leave the children back and get admitted in the hospital. Thus, providing good quality home care for selected COVID patients would be the best way forward. So now question number 2. If we want to provide home care, what factors should be considered for providing home care for treating COVID patients? So basically 3 factors have to be looked after before we decide to provide home care. So these are the patient related factors, the caregiver related factors, and the home factors. So let's talk about the patient factors first. So who is an appropriate candidate for home care? So we need to understand that home-based treatment is not for everyone. We have to have basically case-by-case selection. We have to decide which patient really meets with the criteria, and then only we want to decide if we want to treat this patient at home or not. Certain factors that we want to really consider are whether the patient has risk factors or not, like hypertension, diabetes, comorbid conditions, the age of the patient, social factors as to how big the house is, do they have separate rooms or toilets, and how intelligent the relatives are to look after the patient. The severity of disease is very important, and the local rules and laws of the state have to be followed. We have different rules for different states of India, and ideally, you must follow the state that you belong to. So, who is an appropriate candidate for home care? The person who is asymptomatic or is mildly symptomatic is an ideal candidate for home care. So, we know what an asymptomatic patient is, but what is a mildly symptomatic patient? So, a patient is said to be mildly symptomatic when the patient has uncomplicated upper respiratory tract infection. So, it could be fever, cough, sore throat, nasal congestion, malaise, headache, but the patient is not breathless and there is no hypoxia. The saturation is more than 95%. These are the patients who we can definitely consider for home care. Of course, we have moderate patients also. Dr. Udvadia very nicely told us that certain moderate patients who are adolescents and they have some mild features of hypoxia or dyspnea, but if they know underlying comorbidities and if you're not getting a hospital bed, then you may just consider, but you have to make sure that this is a good decision and you made sure that everything is in place. So going ahead, we please must note that patients who are suffering from immune compromised status like HIV, transplant recipients, patients who have had CA or on treatment are not eligible for home isolation. So even if these patients are mildly symptomatic, you must ideally admit them. Also, patients who are elderly, more than 65 years of age, and have comorbid conditions like blood pressure, diabetes, or coexisting chronic liver, lung, heart, kidney, or brain issues, all of these need not be admitted. They can be allowed home isolation after proper evaluation by the treating medical officer. What is really important is that the patient should agree to monitor his health and regular inform his health status to the treating doctor. The patient will have to fill an undertaking on self-isolation and that he will follow the quarantine guidelines. The treating doctor should satisfy himself all these things before allowing home isolation. Now let's talk about the caregiver factors because this is most important. So a caregiver should be available to provide care to the patient on a 24/7 round-the-clock basis. Please limit the number of caregivers. Ideally, assign only one person of the family as the caregiver, and this person should be in good health and he should not be having any underlying chronic or immunocompromising conditions. The caregiver must be intelligent, he should be reliable, and he should be well informed. He should be taught about the close monitoring for any signs or symptoms of deterioration in the patient's health status, and he should be able to detect these and inform the treating doctor immediately. A communication link between the caregiver and the treating doctor is a prerequisite all through the duration of the home care. Coming to the third factor of home care, which is the home factors. So it is very, very important that we should be able to place this patient in a separate room, which is alone, where he can be isolated, and ideally this room should be well ventilated. There must be a separate toilet for the patient, which he is not sharing with rest of the family. A trained healthcare worker ideally should assess whether the home in question is suitable for isolation. This person need not physically go there. A video also would suffice. It is mandatory that the family members are intelligent and would be able to adhere to the required rules of hand and respiratory hygiene, waste management, restricted movement of the patient and themselves, etc. So only if these things are met with, only then are we going to consider home care for treatment of COVID patients. So after we start considering, the question number 3 is, what is the checklist that we need to be ensuring before commencing healthcare? So having this checklist is very, very important, because in the middle of the home care duration, we cannot just think that, oh, we missed out on this. So there are certain basic requirements. There has to be in abundance presence of triple layer medical masks, ideally N95 masks. There should be eye protection glasses or head shields which are available in abundance in the house. Gloves, sanitizer should be there in plenty. There should be a thermometer to regularly check patient's temperature, and a separate temperature, a thermometer to check temperature of other family people if they happen to fall sick. A pulse oximeter has to be present, and we also have to teach the caregiver how to do a 6-minute walk test for the patient. Baseline blood tests like CBC, electrolytes, renal and liver function, LDH, CRP, ferritin, D-dimer. It would be good if these are already available, and there should be facility for repeat home blood collection as and when necessary, and home chest X-rays as and when required. And this is mandatory because otherwise it becomes very difficult to follow the patient. And as Dr. Gadia told us, bed may not be available when we require the most. Also, it's very important that 0.1% sodium hypochlorite solution for disinfection is made available from the start. So, after doing all this, what is really important is giving instructions to the patient. So, we may feel that it's really easy, but there are so many instructions that we may not realize need to be given. And this is because the patients are not doctors, they are lay people, and they don't think naturally the way we think. So there are certain instructions that we must give to our patients. So the patient has to be told that whenever they are in contact with any family member, they must wear a triple layer medical mask. Ideally, they should be wearing an N95 mask. Dr. Christopher told us that the N95 mask is going to protect the patient and, more importantly, even prevent transmission of infection to the family members. What is important is that after the mask is worn for 8 hours, it has to be discarded, and the patient should not continue wearing this mask continuously even after the 8 hours period is over. What is also important is that if the mask gets soiled or it gets wet, it should be discarded immediately even before 8 hours get over. This is very important to be informing to the patient. Also, the patient must stay in the isolation room, because patients actually ask, can I come out to have dinner with my family? How can I not see them for many days? So they have to be told that they have to be isolated in the room. They have to be staying away from the people in the family, especially those who are elderly and have comorbid conditions like hypertension, diabetes, cardiovascular, lung, renal conditions. The patient should be told that please don't worry, Please don't get hyper. Take adequate rest, sleep a lot, drink lots of fluid to maintain adequate hydration, and eat good, healthy food. And the patient should be asked to follow respiratory etiquette all the time. The patient should be told to wash hands often with soap and water for at least 40 seconds or use an alcohol-based sanitizer. The patient, of course, should not be sharing his personal items with other people. The patient must strictly follow the physician's instructions and medication advice, and the patient should be instructed and should be advised to self-monitor his or her health with daily temperature monitoring, daily saturation monitoring repeatedly, and report promptly if the patient develops any deterioration of symptoms. Okay, so now we told the patient what to do, but the caregiver is a very important link, and we have to give all the important instructions to the caregiver. Now, the caregiver over here is anxious and he's excited also, and therefore, we want to make sure that we give all the necessary and maximum instructions to the caregiver without taking for granted that he already knows. Very important instructions to the caregiver about the mask. So, the caregiver has to be told that ideally he should not be entering the patient's room. If he has to enter, he has to maintain a distance of minimum 1 meter, ideally 2 meters. And whenever he is entering, he has to wear an N95 mask with either protective eye cover or wear a shield which is going to cover the face. And then only he should be entering the patient's room. The caregiver has to be told that the front portion of the mask should not be touched or handled while the mask is being used. If the mask gets wet or dirty with secretions, it must be changed immediately, and the mask should be removed using the correct technique. By removing the mask, they should not be using the front portion of the mask, but the mask should be removed from the behind. This is very, very important. What we take for granted is probably something which the caregiver doesn't know, and this simple tip can really prevent spread of infection to this caregiver and other family members. The mask should be discarded after use, and patient and proper hand hygiene must be done after disposal of the mask, and he should not be touching his nose, mouth, eyes, etc. That is very, very important. Hand hygiene is also very important. The caregiver has to be told that the hand hygiene can be either done with an alcohol-based sanitizer or it can be done with soap and water. If it is with soap and water, then the hands have to be washed for proper 40 seconds. It's a proper wash. Every surface of the hand should be cleaned, and we must request them to see a video on the Google as to how the hand hygiene is to be maintained. What is important is that before and after removing gloves, the patient again has to maintain and perform the hand hygiene. And also, when after the hand hygiene is over, ideally he should be using disposable paper towels to dry his hands, and this should be thrown away. And if at all disposable paper towels are not available, then he should be using dedicated clean cloth towels to dry his hands, and these should be kept separately and they should be replaced as soon as they become wet. Other instructions for the caregiver we may feel are simple, but we need to tell them that the food must be provided to the patient in his room. So basically, the food can be kept out. Somebody can knock on the door and go away, or just call up the patient and tell him to pick up the food. Also, avoid direct contact with patient's body fluids, especially the secretions of the oral and respiratory tract. Use disposable gloves while handling the patient, and to keep dedicated utensils, dishes, towels, bed linen for the patient, and not to share them with the other family members. Any additional information should be given to the caregiver, patient, and the family members? Yes, the caregiver will make sure that the patient follows the prescribed treatment. The caregiver and all close contacts will self-monitor their health with daily temperature monitoring and will report promptly if they develop any symptoms suggestive of COVID-19. Household members should avoid entering the patient's room, and if that is not possible, they should maintain a distance, as I said, and they should be wearing an N95 mask with ideally a protective face shield. And of course, the visitor should not be allowed to visit the patient who has COVID-19. Okay, fine. So now we've explained what care should be taken. But a very important question in the mind of the patients and the relatives is, how do I take care of the patient's clothes, the linen, and the utensils? This is actually very important, and however easy it may appear to us, for common people, it is a very, very important question. So basically, as I said earlier, we must use dedicated linen and eating utensils for the patient. They should be cleaned with soap and water after use, and these may be reused for the patient, but they should not be used for the rest of the family members. A better thing would be to use disposable plastic or cardboard paper and plates so that they don't really need to be cleaned. However, if it will be washed and reused, then while washing, please note that gloves have to be worn while cleaning the linen and the eating utensils. And while cleaning the patient's clothes, they can be either hand washed or they could be done in a machine, but the temperature has to be 60 to 90 degrees. And while we are handling the linen, clothes, or utensils, the caregiver has to wear a triple layer medical mask, has to wear disposable gloves, and has to have eye protection. And this is very, very important because the patient or the caregiver are not going to think of it. And by not giving this information, we are promoting spread of infection in family members of these patients. So after this, a common question that is asked by the relatives is, how do I dispose the waste that has been generated? So the waste should be packed in strong bags and closed completely before disposal, and eventual connection would be by the municipal waste services. However, this is for the urban places. If the patient is in a rural area and if they don't have these facilities of municipal waste services, then the waste can also be buried. Very often, the patient is a lady with a small child and she is breastfeeding. An important question they ask us is, Doctor, can I breastfeed my child if I'm COVID positive and being treated at home? So, we all know that there's insignificant role of breast milk in the transmission of other respiratory viruses, and we all know the benefits of breastfeeding, and therefore, a COVID positive mother can continue breastfeeding. What is really important is that we must tell the mother that she must wear an N95 mask and ideally also wear a face shield while she's going to be breastfeeding the baby or is handling the baby or is near the baby. The mother must perform hand hygiene before and after having close contact with the baby. And I believe milk extraction by a pump would be rather better than direct breastfeeding in case of a lactating mother. Very often, the relatives ask us, I have no symptoms, but I'm going to be looking after the COVID patient. Can I take any drug as prophylaxis? So, this is basically a very controversial issue, but I would like to just basically say that ICMR has actually given guidelines and they have suggested that hydroxychloroquine in the dose of 400 milligram twice a day on day one, followed by 400 milligram once a week for next 3 weeks, ideally should be taken by asymptomatic household contacts who are looking after COVID positive patients. However, we don't have much data about this, but whether this is being taken or not, what is important is that the family or the caregiver cannot take any false sense of security just because they are on the prophylaxis, and they have to take utmost care of sanitization and prevention, infection prevention control, and they have to be very, very particular about this. Then I would like to talk about something again more controversial. Dr. Udvari also spoke about the role of ivermectin as prophylaxis for hydroxychloroquine. So recently, a white paper came out on ivermectin, where some of the leading doctors of our country went through every paper that was published on ivermectin and spoke about in vivo effect of ivermectin. However, with no much in vitro data. Basically, there are two states in India, Andhra Pradesh and now Uttar Pradesh, which has actually said that people who are looking after patients at home who are COVID positive could take prophylaxis with ivermectin. They take one dose of 12 milligrams on day one, 2 hours after dinner, and the second dose 7 days later. This is something which is only for two states, Andhra Pradesh and Uttar Pradesh. ICMR has not recommended this. I stay in Maharashtra. Maharashtra has not recommended this. However, since I'm addressing this question, I have just touched upon this, which has recently been spoken about. Also, a very important and a common question the patient asks us is, what should I eat and what should I take as immune booster? Should I take methi? Should I take turmeric? Should I take Ayush medicines? Should I take vitamins? So our answer should be that we don't know about any immune boosters. What is important is good, healthy, nutritious food, which is most important. Have plenty of water. Good hydration is very important. Lots of rest, adequate sleep. Vitamin C, vitamin D, zinc are too much in vogue, and they are supposed to be reducing inflammation of COVID and improving immunity. However, we really don't know, and therefore at this stage we can't really talk about it. But the best would be good, healthy, nutritious food, good hydration, and lots of rest, and this would be the best immune booster. What is really important is we know what to do, but what we should know is when to escalate the problem to our doctor. When should we be seeking medical attention? So there are certain symptoms and signs the caregiver and the patient should be informed about, and if these are present, immediate medical attention have to be sought after. So if there's difficulty in breathing, if there's dip in saturation to less than 95%, if there's persistent pain or pressure in the chest, if there's mental confusion or inability to wake up, if there's slurred speech or seizures, if there's weakness or numbness in any limb or on the face, if there is bluish discoloration of lips or face, or if the respiratory rate increases to more than 24 per minute. If any of these happen, then immediately the doctor has to be contacted without fail. And now the last question by the patient and the caregiver: when can I be called cured and when can the home isolation be discontinued? Very important question. So patients under home isolation will stand discharged after 10 days of symptom onset and no fever for at least 3 days. Thereafter, the patient will be advised to isolate at home and self-monitor their health for further 7 days, and there is no need for testing after the home isolation period is over. So I've given a lot of information. I just want to sum up by saying that unfortunately the problem of COVID pandemic is on a constant rise. There just seems to be no light at the end of this dark tunnel. We have to understand that if we want to provide good quality care to our COVID patients, we have to make sure that patients who are asymptomatic or mildly symptomatic are adequately looked after at home, so that hospital beds can be kept reserved for those patients who actually require institutional care. So certain prerequisite for home care is that the patient should be asymptomatic or mildly symptomatic. The patient should not be immunocompromised. If the patient has comorbidities or is an elderly person, he could still be allowed to be at home after the treating medical officer has properly evaluated the patient. The patient's house must have a separate room and a separate toilet for the patient. Intelligent, well-informed 24/7 caregiver is mandatory. The caregiver must take full responsibility for being in touch with the treating doctor, and there should be an undertaking by the caregiver and the patient that they will look after themselves. To conclude, careful patient selection, adequate education of patient and caregiver, and optimal monitoring can make home care for COVID-19 the alternative standard of care and can help us handle this pandemic better. Thank you.
Rita, that was very well presented, and I think, as I said in the introduction, you have made it very practical and just the tips that people require to carry this out in their homes, and for doctors to advise patients about home care, advise home caregivers. I think you have put down everything very well and in a very clear fashion. Thank you very much. So we will move on to discussions. I think there are a lot of questions. So I'm going to go on some kind of a rapid fire mode. I hope you are both prepared. So I will answer the first questions. The question is, does HRCT correlate with clinical course? And the related question is, for home quarantine patient, is a CT required? I think both very important questions, especially the second one. I'll answer the first one first. Now, HRCT, does it correlate with clinical situation? It probably will, especially with the respiratory situations, especially with saturation. The more the shadows seen on imaging, more the ground glassing, the more the desaturation potential will be. Obviously, there will be difference in clinical presentation depending on patients' buffering mechanisms, patients' reserves, and those with underlying lung disease, those who are elderly, may have symptoms much more for a given quantum of radiologic shadows. With regard to should patient have a CT scan during home quarantine, I mean, the quick answer is absolutely not. This patient has been deemed to have a mild disease, and that is why he has been recommended home quarantine or home isolation. And therefore, treat him like he is at home with the sufficient medical inputs that have been very nicely outlined by the two speakers who followed me. Those are the things we need to do. We should not we should not make a hospital around the house. CT scan center and oxygen center and so on and so forth. So definitely not. Mild infection should be treated like a mild infection. Let them rest, recuperate in peace, check the saturation, and make sure their other symptoms are under check and the saturation is normal. Okay, now I'll go on to Zarir. One question, Zarir, is do you do blood biomarkers for mild COVID?
DJ, the only
I'll give you another question, Zarir, so just to save time. Why is there so much variation in patient care between doctors, especially with the use of drugs? So please take them one after another. Blood biomarkers and variation between doctors.
So, BJ, the only test that I would do, even on a mild patient at home, is a CBC, a CRP, and a D-dimer. Nothing else. Those are the only COVID-specific tests I would do. I think it's a colossal waste to ask for tests like IL-6 and ferritin upfront for every patient. They don't have a role. Why is there so much variation? DJ, this is a new disease for all of us, and basically we have to train ourselves. We're like pilots who are flying without the manual in front of us, literally. So all of us, consultants like Amita and me and you, have trained ourselves. And it depends on your philosophy. The general practitioners need to do their bits. Webcasts like this do their bits. But there is a great variation in medical care and medical doctors all across the country. And that's being highlighted just now, when often bizarre combinations of drugs like the prescription I showed you are sadly used. And as I said, many drugs I do believe will in the end be shown to do more harm than good when the final total is made at the end of this pandemic.
Yes, well said, Zarir. I think we have been learning on the job. We did not have a manual when we started treating these patients, and we are learning from each other, learning from people who had patients before us. Amita, what is the difference between viral cold and COVID upper respiratory symptoms? I'll give you another question as well. Can vitamins improve immunity?
Okay, so very interesting question. So the thing is that the viral cold and the COVID upper respiratory tract infection is just the same. COVID is also a virus, so the symptoms are exactly the same. But however, because this pandemic is going on, every patient who has a cold, we have to basically think about COVID. Over here, it's important thinking about COVID because about the spread of infection, you have to consider COVID. And if it's COVID, then you want to basically isolate the patient because they will cause spread of infection. So this is the basic difference between a common cold and the COVID cold because isolation is required, which otherwise was never required till date. That is the first question. And the second question is about the vitamins improving the immunity. So frankly speaking, I really don't know. I basically personally feel that vitamin D3 is very important. I kind of feel that it probably improves your immunity if not against COVID, then definitely against TB. So I think it would be good to have good vitamin D3 levels. Vitamin C for many, many years is known to be good for common cold and viral infections. Very often we end up giving it because the patient feels happy and safe. We don't really know. Zinc is something which has really become in vogue and it's got so much of visibility which it never had before. But zinc basically came in vogue because of hydroxychloroquine, because zinc was supposed to be improving the entry of hydroxychloroquine into the cells. Now that hydroxychloroquine is not being used much, I'm not myself really sure how much zinc would be required. Multivitamins would be probably good because if you're taking antibiotics, then it's good to have multivitamins to prevent glossitis because otherwise it will reduce your food intake. And if you're on DEXA, please take calcium. It would be good.
Right. I think all very useful points, Amita, useful especially for practice. I think, yes, if there's vitamin deficiency, D deficiency, which is quite a rampant problem in our community, I think in any case, it is good to make sure that that's corrected.
If I can make just one small point, DJ.
Go ahead, Sari.
In terms of the symptoms, I've often been struck at how very mild and non-specific the symptoms are in so many patients. 99 fever one day, a bit of cough which goes by day 2 or day 3. Such patients really don't need any treatment, but of course you need to continue watchful observation.
Yeah. So mild symptomatic, asymptomatic disease is the hallmark of this problem, and that really is what makes it lethal. If we know who's sick, then we can isolate them. If people are spreading whom we never suspect, there's a problem. Yes, Amita, you wanted to say something?
This is a candid confession. This is my thought process, which I'm very candidly expressing. I basically feel that if we use, even if the patient has mild symptoms, if we use an antiviral early, then we are not allowing the viral to replicate. And if the virus is going to continue replicating, then a small number of these people are going to end up having a huge inflammatory reaction and the cytokine storm. So I don't know, somehow in my practice, treat each and every asymptomatic or mildly symptomatic patient. It may be controversial, whatever, but this is my belief that if I can control the viral replication, then I'm preventing these patients from an avoidable cytokine storm, because today we have no idea who ends up getting it. Because of late, in last 2 weeks, we've had patients who are 30 years and 28 years, fit looking, exercising individuals with no comorbidities, who just, they've like one day of cold and 99 fever, 7 days they've come with saturation of 80%. So I kind of feel this is something that I'm doing.
Yeah, thanks for that, Amita. I think we are all awaiting well-conducted studies that show that the promise that antivirals show, especially in vitro, is replicated in vivo and in real patients. So I think studies will roll out, and we will know more and more as we go by. So there's a question here about how many days after symptoms do you do RT-PCR? So when we started, I used to ask patients to wait for 3 days or 4 days before they did RT-PCR. Then I looked up some literature and I found that even if you do it as soon as you see the symptoms, it is pretty much positive for most people. So really there is no need to wait. As soon as patients are symptomatic, RT-PCR can be done. There's no need to give time for it to become positive. It is positive about the time they are symptomatic, so there's no need to wait. Then there's a question about how are people who are largely indoors getting infected. I think I've heard this question come from several quarters over the months. How, doctor? I have never gone out. I have never met anyone, kind of thing. So I have definitely a small cohort of people who have been largely homebound, elderly people. They avoid meeting everybody. But the reality is that they need to be looked after. So there are caregivers who are usually poor people, who usually come from humble abodes, crowded abodes, from slums, who quietly come in the morning and go in the evening. And of course, The elderly people have been warned if they have cold or fever or anything like that, warn them not to come. And today, as Zarif said, there are some cohorts where asymptomatic infection is as high as 70-75%. So, in all likelihood, it is some well-meaning helper who has inadvertently passed the infection. That is, it can't just come out of thin air. It has come from a human being, from a person. Now, airborne transmission is by and far the most important. Another reason we can invoke is fomite transmission. If I come from hospital and do not hang my coat or hospital scrubs securely away from contact, and my elderly mother handles it and puts her hand in her nose or mouth, yes, theoretically she can get infected. But the risk of that happening is not very high. But these are all the possible explanations. Okay, now I'm coming to a fairly controversial and thought-provoking question. So I want both of you to address this one. Amita, you can go first. Why is Mumbai and Maharashtra unable to control the pandemic? So what are your views on why? Well, they have said Maharashtra, so you are Maharashtrians. You can start with Maharashtra, but you can give insights about the challenge in this regard.
Okay, so actually, it's unfortunate that we are the COVID capital of the country, and from day one, and I think we'll just continue being there. It's extremely unfortunate because I kind of feel that probably people are illiterate, number one. The second is the attitude of the people is quite casual. And the third thing is that probably there are too many industries, and therefore very often the common person is forced to come out. So, and the thing is that, and these end up being the transmitters of infection. So I kind of feel that somehow we have to really get some kind of, and also the thing is that everybody has their own prescription, as Dr. Udvadia told us. If we tell 10 doctors to give a prescription, all 10 will write different prescriptions. So I kind of feel that it's very, very important that there is education among doctors and education of people, and we do something really drastically about it, because things are just getting worse every passing day.
Zarir?
DJ, basically COVID just holds up a mirror to the inequalities of society. You follow? Bombay is a country with 20 million people. 50% of Bombay lives in slumlands. The same factors which make which make Bombay, as you know, the TB capital and the MDR TB capital of the world, apply to any airborne infection. As far as self-isolation or home quarantine, which Amita has so nicely summarized, how can we expect to do it in Dharavi, for example, where 20 people, 30 people will live in a room the size of my living room? So basically, it's, in terms of face mask wearing, I'm always pleasantly surprised that even the poor person on the road is masked up. And in fact, a study showed that we're doing much more in terms of public masking than America is, where they have these crazy Republican right-wing chaps who think it's a matter of pride not to wear a mask. So we're doing what we can, but I think Mumbai is where it is because the injustices of society are exposed most in this so-called maximum city.
Okay. So we'll go to the next question. I'm going to again ask your views as well. So how far are we from herd immunity? And I will club it with another question. Is India in phase 3? I mean, this has been talked about so much in the news. People will say now India is in phase 3. So do you agree that India is in phase 3 only now? And what is the what is the time we are looking at for herd immunity? Zarir and then Amita.
So no one knows the level at which herd immunity will start to operate. Is it 40%, 50%, 60%? We really aren't sure. These seroprevalence surveys, and Amita, I think you had mentioned, DJ, the one from Delhi, and there are several from Mumbai. Remember, are in small pockets. So herd immunity and the spread of the disease in, say, Dharavi is going to be different from what it is in the posh Malabar Hill localities of Mumbai. India is part sub-Saharan Africa and part Southern California, the rich and the poor. So we have pockets where we have herd immunity, but nationwide herd immunity we're a long, long way away from, and so is every country in Europe and the US. Now, in terms of phase one and phase three, it's difficult to say. To be honest, I don't know what you mean when you say phase three. All I can say is that the Indian government till recently was denying that this disease was even spreading outside of travel-related and in the community. So these are all semantics, but basically the epidemic is mature. It is expanding at an alarming rate, as all three of us can vouch for. And we are still very much in the midst and in the throes of the first wave, without need to talk about second waves just now at least.
Yeah, I totally agree. I kind of don't know what the phases, but the problem is real and the problem is here to stay, and we have to face it. That even if we are trying to do lots, this is not enough. And we really need to gear up, we really roll up our sleeves, and we have to do something drastically effective. Somebody really needs to think how to sort this out, but we really need to. Because I don't see it ending for next 6 months.
Yeah, completely agree with you, Amita. I really do not. I do not see the light at the end of the tunnel. It's probably there somewhere, but as we speak, we are unable to see that. So at some point, we'll start seeing that, and we can predict when we will reach that light. But as we speak, things are still very unclear. There are some practical questions. What is the role of steam inhalation with regard to COVID? And is testing required before discharging patients from hospital? Amita, do you want to take this too?
Actually, I personally don't think testing is really required, because we all know that the virus can live up to 20 days. So if more than 20 days are over, then I kind of don't see any reason why to test, because because it's an RT-PCR, the report may come positive, and then the patient doesn't want to go home. He wants to continue occupying the beds which are already so low, and at the same time, the home people are not very kind to take the patient back in. So I personally am not really in favor of testing. That is what my take is.
Yeah.
And I forgot the first part of the question.
Steam inhalation. Do you think there's any merit in steam inhalation?
Steam inhalation, basically, for patients who are not COVID, somehow I'm not very fond of steam inhalation in life, because I kind of feel it dries up the respiratory mucosa, and I kind of feel that it makes us more susceptible to infections. So patients who are COVID negative, to prevent COVID, according to me, I would definitely not recommend steam inhalation. Given that very often there are some patients of COVID positive who have a lot of chest tightness, and they do feel good after taking steam inhalation. So this particular group could be given for 3 to 5 days, but I wouldn't recommend 2 or 3 times a day endlessly.
Okay. Two interesting questions for you, Zarir. One is about aspirin prophylaxis. The second one is about when is the time to start pirfenidone? Presumably, the individual is talking about the fibrosis and interstitial disease that follows.
So as far as aspirin goes, it's not been put to an RCT, but there is observational data coming in that patients who were already on aspirin, who were already on statins, for example, seem to have COVID less frequently. That's not solid enough data, really, because the RCTs are not available. The second question is even more interesting, DJ, because all of us will vouch for the dreadful pandemic of fibrosis in the lungs we are seeing in many patients. And the honest answer is that we don't know the natural history of post-COVID ILD. In the previous SARS-CoV-1 epidemic, not pandemic, we know that up to 3 months and 6 months later, patients actually improved in terms of their physiology, in terms of their CT scanning. And there are fascinating reports of even fibrotic bands and shadows disappearing over time. So time is really the best healer. If you start pirfenidone when your patient has a honeycomb destroyed lung from COVID-2, it's too late to help him. And in the early days of COVID, you're scared to add, when the patient is on a ventilator or very sick, to add something new into the mix, something which can upset the liver, for example. So basically, we will need randomized controlled trials, and you'll be happy to know that there are already trials of inhaled pirfenidone and oral pirfenidone to try and answer this question. What role will these antifibrotics have? So I would use it circumspectly in a few patients, not all patients. Again, it's being thrown around like water, and one is not sure till you get some data from RCTs.
Sure. I think that's a very balanced answer. Often, unless we do something, we think we are being ineffective and we are not good physicians. If you see a problem, we have to do something. Sometimes it's better not to do anything, even if things are not going so well. It may be better not to do some things than do certain other things which could make things even worse. So, well conducted studies, I think, will answer this question, and I'm sure, I'm glad to hear that trials are underway, and we hope.
Can I just be the devil's advocate over here?
Yeah.
So basically, I completely agree with Dr. Upadhyay. If at all you give antifibrotics, it has to be really case-based and very case-selective, because these drugs are hepatotoxic, and so is remdesivir or favipiravir and many of the drugs that we are giving. My only thought over here is that COVID is different. The thing is that inflammation over here is supposed to go on for 3 months, 4 months, up to 6 months, which wasn't seen in the earlier SARS diseases. So I kind of feel that if a patient has inflammation, which is if the patient has had a long bad course, and if the X-rays are still getting worse, and if new opacities are coming even after 3 to 4 weeks, then maybe there might be some role of antifibrotics, because we know that antifibrotics prevent fibroblast proliferation, and they may technically prevent fibrosis in these patients, because once we get fibrosis, the drugs may not really act. So I kind of feel that case-based, of course, but maybe we should not be very rigid and wait for the results of trials to come out, because those patients who end up with fibrosis, what about them? It could be a very open discussion with an intelligent patient about the pros and the cons.
Yeah, sure. I think the last has not been said on this matter. So we'll wait and see how things turn out. I think the next few months, I hope we have some answers. And I really hope there is some drug that helps these patients. We are seeing more destruction of lung and more interstitial disease than we ever imagined. We never imagined that we would have a scenario like this. We expected some subtle scarring, but never the kind of changes that we are seeing now. So let's hope and pray that indeed some drugs come by that can be used to slow or even reverse these things. So we are almost drawing to close. I have two quick questions. So Zarir, there's a question here. It says, can wound abrasions be infected with SARS-CoV?
Can what, sorry, DJ?
Wound abrasion, so open wound. Can SARS virus go through that?
I'm not sure, to be DJ. I think it needs to latch on to ACE2 receptors, basically, and those are prevalent in the nose and the pharynx and the gut, but not in wounds. So the proper answer is no.
Yeah. So, it needs, as Zarit said, the key to the body is through these receptors. And if it doesn't go to those receptors, it can hang around elsewhere and probably won't find its way into the body. So probably the chances are small. And I hope we don't inoculate wounds with SARS-CoV viruses anyway. So I hope we won't do that. So the last question is this. Are you seeing dengue co-infecting with SARS-CoV? We have actually, with the rains recently, we had patients with fever and some persisting fever and some atypical features. And then dengue serology became positive. And so now I am sure we have at least half a dozen or more patients who have dual infection. So while COVID-19 is a problem, we should not forget that that doesn't make them immune to other infections. The same is true for tuberculosis. We have seen TB hiding under SARS-CoV-2. One of our junior specialists happened to be on COVID call. He looked at the X-ray and said, no, this is not typical of COVID. This looks like TB. And then, of course, the patient was expert positive. So the patient had COVID. Patient also had tuberculosis. So, do you have anything to add, Zarir and
I think with the dengue question, you see it quite often, in fact. And I think one clue is the fever just persisting, longer than you would like. and you wonder if there's some other cause. And another very important pointer is the platelet count is low, which it should not be in any COVID, except, of course, end stage when they're septic and dying on a ventilator. But a low platelet count in this condition, early up, say 100,000, 120,000, again is often a pointer that you could be having dengue and COVID together.
I totally agree. In addition to, we've seen a lot of dengue and COVID, and we've seen a lot of malarias also. And strangely, every malaria has been buybacks. So this is very, very strange. COVID with malaria, COVID with dengue, and very often the COVID fever goes away and the patient gets fever, and we send these things that they turn out to be positive. So we basically have to, consider the possibility of dual infection and look for it.
Right. I think there are questions just flooding in. So I think probably I will take one question more before I close. There are far too many questions, and I don't think we will have time to answer every one of them. Having said that, they are all excellent questions. I will just take one more. There was one on. Yes. So this question is on reinfection. Maybe we'll take two questions quickly. So this one is on reinfection. So maybe one of you can take this one. What is the risk of reinfection, and should we be very worried about it? The second question is on plasma therapy. What is the evidence for plasma therapy? What is the status today?
So reinfection is extremely rare, so rare that it needs to be written up when it does occur. It's difficult to prove. You need a good lab to be able to prove that it is a different strain this time. In terms of plasma therapy, like so many other COVID interventions, we don't have any RCT-based evidence to date, although it's thrown around, that it actually works. In fact, every study these days says that maybe it doesn't have any real role. So again, we're waiting for evidence. The Mayo Clinic has a series of about 30,000 patients now. There was marginal benefit and no mortality benefit. So interestingly, we come back to steroids as the only intervention and the cheapest, which still makes a difference to mortality.
Right.
Yeah, I totally agree. Reinfection is is uncommon, and if at all the patient gets it again, COVID infection, we have to make every effort to prove that the genome is a different one. That is important. And plasma therapy, again, no comments, because I'm not really sure whether it helps. It's become like, everybody gives it, so you end up giving it, but I'm not really convinced that it works.
Thank you, Amita. So I agree with both of you on that. Plasma therapy, I think ICMR has also released its advisory on that, saying that in their trials, they have not so far found any added benefit. So as we speak, I think evidence doesn't support its use. So I think that's a good way to close this interesting meeting. And just a note of point of encouragement, really, that if you are a COVID patient, don't worry about reinfection. The chances are extremely, extremely low that you become a case to be written up or a part of a case series. So it is that rare. If it is common with lakhs of patients, we would have seen so many people coming with reinfection. We have not. So we have to now assume that for practical purposes, once infected, you have the immunity to protect you from reinfection. And that's a comforting feeling. Having gone through the pangs of the disease, at least you come through knowing that you probably won't get infected again. So I hope that's a good note to call off today. I want to thank my co-speakers and co-panelists, Dr. Amita Nine and Zari Rudwadia. I think the session could not have been so informative and so interactive but for their contribution. I thank them for really coming with very practical, very scientifically appropriate advice to the listeners. And I myself learned a few things from them. Thank you very much, and I look forward to sharing the podium with you more in the years to come. Want to thank Dushyant Lal and his team in Abbott.
And
I
DJ,
think
you have to agree, DJ, that Amita was no lamb; she was more a lioness with the two lions.
right. Yes, yes.
You know,
The lioness between the two goats.
no, no, no. I'm telling you, I was so nervous, and I was sandwiched in between the two of you. Luckily, the order got changed. Otherwise, between two lions, there was a small lamb trying to just survive.
Right. Anyway, I think your contribution overshadowed ours, I should say, Amita. Thank you
That's
very
really
much.
kind of you. And
Yeah.
it was fantastic listening to you and Dr. Badia. As always, you all gave the most spectacular talk. So informative and so
Thank you.
and it was
Dushyant,
wonderful.
thank you very much.
Yes, sir.
And
So,
thank the Abbott team for us, for all that they have done and given us the freedom to plan this informative kind of a webinar. Thank you very much. And the listeners, I have to thank all the people who logged in and have listened to this and have interacted. I really wish we had more time to answer your questions. There's so many questions. Although we tried, we could not answer every one of them. Thank you very much for asking those questions. Goodbye.
Thank
So
you.
thank you. I would like to thank each and every speaker and panelist for wonderful oration, and it was nice. It was a nice learning experience and very informative session you people have took. And I hope that everybody out there have learned a lot about managing mild to moderate COVID-19 and how to do it at home care settings. So thanks for that, Dr. Amitan and Dr. Christopher and Dr. Zari. And I would also like to thank our commercial colleagues for setting up this whole webinar and giving us those freedom that Dr. Christopher is mentioning, that we can do it at patients who are being managed at home care settings, and keeping it unbiased and very open for all the audiences there. And I would also like to thank the live audiences who has joined us out of their hectic schedule and being a part of this live webinar. And I hope that you people have learned good tangible outcomes out of this pertinent webinar on mild to moderate COVID-19. And at the last, I would like to thank our digital partner DocMode for giving us this platform for very smooth transition and for a very smooth conduct of the webinar. So thank you everyone, and it was a nice learning experience for all of us. Thanks again to all the panelists, and I would now close the show by saying a very relevant message in today's era, that Namaskar, stay safe and stay healthy.